Good evening, friends. I am Dr. Harshvardhan Mardikar, and I am the Organizing Secretary of the CAD meeting. And now we are starting the first live case presentation of this CAD meeting. Can I have the projectors on? And in the meantime, I take this opportunity to invite Professor Dr. Khalilullah, Dr. Rayan Anis, and Dr. Uday Khanolkar, chairpersons for this live case presentation, Dr. Chetan Shah, Dr. Sunil Modi, Dr. TNC Padmanabhan, Dr. Narendra Gadkar, and Dr. Kajol Ganguly. So friends, what you are seeing here is something which is not what you see in live case presentation in India every time.
Balloon is coming from here?
Yeah.
Correct.
So MS, please hold on.
We'll go into main branch.
So what you see here is first time in India you are seeing high definition transmission of a live case. And what you see on the right hand side is Dr. AMS Hiremat, who is on the high definition TV. On the left hand side you will get the right hand side you will get the coronary angio from the screen. And these two channels are different. What you see in all the meetings, what we do in India, two channels are mixed in picture format. And all this is happening because what you are seeing at the back end, a big projector. If you look at that light, it's very bright. And this is what is happening. From one single source, you can get 2 feeds of live case. So I hope you will enjoy this transmission, live cases, and many more live cases will come in course of time. Thank you very much.
Sir.
Hi, everybody. So we are here in Ruby Hall. Firstly, a big thank you for coming for this meeting. We all worked very hard for this meeting. And we are beginning the live case. Marie-Claude Morris is in the other hall, and it's not easy to be working on the same floor as her. So what we have here is a LED diagonal bifurcation. And you can see for yourself critical stenosis in the diagonal margin. Let me give you a little story. Can we have the slide? This gentleman actually was angioed in 2010 beginning for effort angina positive stress tests. And the diagonal lesion was rated around 80-85%. He was advised to stay on medical treatment, but he continued to progress with effort limitation and one recent admission in a peripheral hospital for ACS. So we have brought him back and the angio showed a very critical diagonal lesion. The diagonal you can see is a very long vessel, multiple branches. Can you freeze this? So now we are with various options for handling this critical diagonal lesion. How many of you think LED lesion is also tight and needs to be addressed and could be contributing to angina? Who all are in the chair?
Hello, Shirish. Can you hear me?
Yes.
This is
Yeah, very well.
Uday Khanolkar here.
Hi, Uday.
Next to me is Dr. Khalilullah, Dr. Gadkar from Bombay.
Dr. Rayan, and he's from Bangladesh.
Hello, Shirish. I'm Dr. Kajol Ganguly from Kolkata.
Hi, Shirish. This is Dr. Modi from Delhi.
Good. I'm going to have
Dr.
great
Padmanabhan
support
from
during
Hyderabad.
handling this lesion. Hi, Dr. Padmanabhan. So the diagonal certainly needs to be addressed. So any thoughts as to how somebody would do it?
The LED lesion, see, Shirish, we are at a little bit of a diagonal view from the chairpersons because the screen in front of us is not functioning. From the place where we are sitting, the diagonal is significant, about 90% plus, and about 60% lesion of the LED. And LED doesn't appear to be too significant from the place where we are looking at it. I will ask the opinion from my other colleagues over here. Dr. Khalilullah?
I think it's primarily a diagonal lesion, the ostium as well as further down. The LAD is not really significant. I totally agree with you, although there is some lesion, the range of about 50% from proximal to
Okay,
the distal part of the diagonal.
Actually, we had the same kind of feeling last year when we angioed him, and we thought the LAD is not important and stay on medical treatment for diagonal. However, it's pretty clear to me that if you're addressing this diagonal, LAD has to be looked into. And we are actually now doing an IVUS for you. Are you able to see the IVUS?
Yeah, before you proceed with the IVUS, in this lesion, what would you favor, an IVUS or an FFR?
Shirish, can we see the left anterior oblique view? This lesion of LAD is
LAO.
likely to be very eccentric.
What are you seeing, at the angio or IVUS?
We're seeing the angio and the IVUS actually both.
Even on the angio in left anterior oblique view, I'm quite convinced that LAD has a very significant stenosis.
I also think that
It is
even
an
before-
eccentric lesion, and that's
So
what
the
I think we are
bookmarks.
going to see in the IVUS also.
Can somebody consider FFR in this patient for the LAD lesion?
Show him.
Kanolkar, would you like to ask him
So
whether FFR can be done in this patient? FFR
We'll
for
show
this
you the
lesion.
pullback. Run that. And as you can see, this is the diagonal coming up, and you can see sizable atheroma in the LAD, and this is on the back before the origin of diagonal. I'll show it to you one more time. From distal to proximal. Just freeze that diagonal origin. Freeze. Go forward. Go distal a bit. See, this is the LAD, just distal to the origin of diagonal. It's pretty convincing to me that we have a significant lesion. So we go back to the cine. And what we propose today is a dedicated bifurcation stent. Can we see the box of the... so this is Nile Pack's dedicated bifurcation stent. We have to understand, can somebody show the animation there in the hall? In the meantime, this is a bifurcation stent. Can you bring it here? Just hold it in front of the camera. We have actually, so the 8 millimeters is distal to the carina. 10 millimeters is proximal to the carina. So this length is 18. The 8 millimeter is a set distance. If you choose a longer length, like instead of 18, I have choose 24, the 8 still remains constant, and the back portion will increase from 10 to 16. So 8 is a constant figure. And that's the side of the stent. Show the epicranial again. And see here, we are going to get the 8 millimeter beyond the carina. So first we dilate the lesion. We have two wires. This is a Cougar XT from Medtronic. This is a non-polymer wire. It's pretty good for long usage because of no polymer. This is a BMW going into diagonal, show back, and this is a mini trach balloon from Abbott. This is one of our favorite balloon for difficult CTOs, and we go up on 1.56 to high pressures. Then we come in with a Yangtze balloon. This is a balloon by the Invas company itself. And we go high pressure on that. Show the images after that. And same is done to LED. Let's jump some sequence. And we'll show you the current picture. Let's take contrast.
What was the size of the second balloon in the diagonal, the diameter?
We have used 2.5. So now we are ready, open the stent. Is anybody able to show the animation for you all?
No, there is no animation
Can you
over here.
freeze this? So actually what we have decided is to reverse the stent. That means 8 millimeter diameter, open the stent, which should go into LAD, which is a main branch, is going to get transferred to diagonal. So for the stent passage, we are treating diagonal as the main branch, and we'll have just a small opening at the mouth of LAD, and we plan to attach a stent to, I need to focus here, to the LAD. So this, are you able to appreciate Dr. Krishna's finger movements? So this is the diagonal wire which we are treating. This is a LED wire, and we are treating this as a side branch. 1 minute. Before you take it in, are you able to see this? The side stent is here, and the other stent is here. So one wire will go from here, and the other wire will go from here. I don't know whether I'm clear enough. So this is which wire?
MS, before you proceed,
So
you
the
have got
LED wire takes the
MS. Can you hear me?
side branch.
Hiremat?
Yes.
Okay.
Yeah.
Now you have got these two
Go on.
wires going into LED and diagonal, and one balloon system which is going over two wires. Now if the wires have crisscrossed somewhere near the left main,
Take another same size balloon. Take another same size tent. You want to switch? Okay, go quick. Hello?
hello?
Nothing.
Hello, Uday, we are switching you to Mary Morris's room
Okay.
because she wants to show you wiring of the LED.
Okay.
Okay,
Hello, can you hear us?
Yeah.
Yeah.
Are we on?
Yeah.
Hello?
Yes, we are on. We can hear you.
Yeah. This is a 55-year-old gentleman. Had an anterior wall infarct, was thrombolized with tenecteplase. It's around 3 weeks. And just show you the angio. Just playing the angio. Stop.
We are not able to see the angio.
Ah,
They've not seen the angio. Show them the angio.
Yes.
So it's a recent MI with failed thrombolysis. You will see that the LAD is still occluded. And single vessel disease, right is normal and circ 2. Can you see the angio?
We cannot see
Could
the
you
angio. There is a
please
transmission problem here. Yes, now we can see.
Okay. You have it?
Yes, it is there, but what we can make out from the transmission is there is a small stump of a LED seen there. Is it right?
Exactly. That's exactly the point. Height is normal. We don't see many collaterals from the height. And you can see it. Very little collateral, but seems to go high. So the occlusion for sure should be short. And we are lucky, if you go back to the LAD, we are lucky to see that there is a small stamp. You see? You see it? So together with my partner, Dr. Sanchez, and this nice team, we will try to open this. We see very well the stump there. So we'll try to go through this single lesion. The selection is 6 French femoral. We have an EBU 4 or 3.5. 3.5. And I prefer to take, because it's not a CTO, but not very, very recent, I took a Fielder XT to go there, to try to go there. So I'm trying to enter okay, I think it's exactly here. Now we have to find our way gently. Clearly the lesion is there. Okay. I'm moving gently the Y to try to cross. Maybe it would be good to have the support of a small catheter, but it will not be easy to get it there.
Uday, can I ask one question?
Yes, of course.
Yeah, I want to know if the patient is asymptomatic and he has a totally occluded vessel after an MI and thrombolysis, is it the right time to open, or you would like to still wait for a couple of weeks more, because as per the OAT and the TOT trials, you need to wait for at least 4 to 6 weeks before you start opening these vessels, because otherwise the complication rates and reperfusion injury is very high.
Honestly, except when there is an enormous amount of thrombus, I don't think that early opening is dangerous. The problem is that I'm not crossing there. Can we use a microcatheter?
Yeah.
Like?
Yeah. This is okay?
Here. Is okay, ma'am? Fine cross, ma'am.
Yes,
Yeah,
a fine
fine
cross,
cross, yeah.
yes, good.
खाली डालने का है ना डाला जाएगा
Because you see that I'm not progressing. I'm entering the lesion but not progressing. So I think the best is to take everything off, to enter the Y in the fine cross. If not, we will. If we push, we will prolong it.
One back flow. Right.
And retry with the support. Because you see the Y alone was not enough. Huh? In a little more. Oh. A little bit more. Thank you. Okay. And now you can advance here. Perfect. Okay, so now we are, maybe if you can use the torquer again. Thank you. Okay, I think we lose our shape. Okay, I will reshape it, won't take long.
I have a question. What was this patient's echo like, the anterior wall?
So how is the function anterior?
The total ejection fraction is around 35%. Well-preserved thickness of the anterior wall, not scarred and thinned out.
Would you
Okay, so it's of particular interest to try to open.
One more question. Why means is there any inhibition
Yeah.
for using a 7 French catheter? Because it is involving the ostium of the LAD, and if the ramus get pinched and you have to do a simultaneous balloon dilatation, 7 French would have been better off, or the support provided by the 7 French would be better?
Let's say personally, I use most of the time in 6 French, and we can do near everything like that. So even bifurcation, even left main. So what I will try, you see that again, we are not crossing. So what I'm doing to try is to advance the microcatheter. Okay. I'm still at the right place. It will not be easy, but we need the support of the catheter to go in. Okay. Continue. try to put this catheter closer. Okay, now it's very close. I'm again in the stump. Okay, I think this is the best support I can get because the catheter is not turning.
Can you hear me?
Yeah.
Yeah. You see the angle. That's what is the force is not being transmitted. Can we take a little bit harder tip void? The
Harder
angle you are
tip,
having, that
for
90
the-
degree, it's hopefully it's not going to cross.
Yeah.
So my advice will be take a little bit harder void. You see this buckling.
Yeah.
Moment you will push, that it will come out.
No,
And the
I
angle is-
agree,
and,
but let's say
Try to deep throat this
Let's
guide as well. That will give you a little bit better angle. If you'll push the guiding and change the little bit tougher wire.
more support from the guiding, okay?
Yeah.
Why not? Okay. This is done.
Yeah, there will be more better alignment with this.
The problem is that the catheter doesn't turn, which is not so surprising.
Take a little bit stiffer wire, I think.
Yeah. We will have to finish with a stiffer wire. But let's say, always prefer to begin with a softer one. Because it's something recent. It should be easy to cross, but it's not. Okay, so what's next?
Which do you want?
Huh?
Which do you want? Cross it? Or,
Mary?
Would you like to change
Yeah.
the wire now?
Mary?
yeah, we are changing the wire.
Yeah. I will change.
Mary, this is Dr. Ashwin Mehta.
Yeah?
I wonder whether, I think I would stay with the choice of polymer wire with a higher tip load, something like Pilot family.
Let's say,
Pilot,
yes, we can.
Pilot 150 or the small
Yeah, we can try
Pilot
this. Yeah, we can try this. I like the concept of the hydrophilic, but
Cross it, Kudle, cross it.
clearly the problem is also my catheter is not turning at all. Huh? Okay, so let's try.
Kudle.
Yeah, a pilot. Yeah. Oh. Okay. What do you prepare?
What do you want? You want
Conquest Pro is too tough.
too tough. You want a Shinobi? That should work.
Yeah.
Give a Shinobi, yeah.
Yeah.
Give a Shinobi. That will work.
Okay, so I leave the microcatheter there. So second choice is a Shinobi. So it's stronger.
Can I have small
very
comment,
small
please?
curve distally.
Can I have small comment, please? Yeah, but I feel is that
Yes?
in this patient, microcast not going to work because there's a sharp angle there. Can we use venture caster here? Because once you drag the tip towards that LED,
Yeah, that's yes, that's an option. But let's say no, it works. Yeah, it works. But venture catheter are sometimes a little dangerous. Oh, sorry, I missed.
that will stay there in LED ostial when you turn toward that caster.
Because I don't want at all to damage my left main. This should be a priority. So I am so with the Shinobi, maybe a little bit more distal. Yes, we are more distal test. Maybe we can go epicranial to see now where we are going. Okay, this is not bad. No? There is a strange. But maybe we have tortuosity. I am clearly in a vessel because the.
Can we make use of the contralateral injection to confirm?
No, there is no. We don't see anything from the right, unfortunately. Or near nothing.
There is some retrograde flow from RCA.
No, always going same direction, which is probably. But let's see if the. You see the catheter is well following this time. So.
What do you think is the direction of the guide wire? Where is it going? It's a little bit of a strange.
Probably entering in some
Yeah,
diagonal.
it's strange, but let's say my catheter. I'm sure that I'm somewhere. Maybe we can take back the other one, softer
Other
one,
one?
because the catheter is more distal now. Or maybe try a small injection in the gentle injection in the catheter.
You want?
If you have a small,
Yeah, I will take
yeah,
this. Contrast. Contrast.
small
Contrast.
syringe with dye. Let's try.
Yeah,
You see?
you are.
That's
That's the LED.
we are in the lumen. So I think that coming back to the soft Y, you see the Shinobi helped me to go somewhere, and now I'm happy with this. So I take the softer Y, not to take any risk with the of dissecting. Okay, thank you. Okay. Okay, so we are sure now that we are in the LED, yeah? So,
Balloon box. Box.
we will take this off by, yeah. Yeah, this is for sure. You know, can you show what we are doing? We are flushing yes, if you, I would like to see the end of the tip of my, yeah. At how much are you? Good. Okay, that's perfect. So that's a good way of taking off. Yeah. Oh yes, you can, because you saw the most important, which was crossing with the Y. After that, it's just a matter of. So you can switch, and we will show you what we did after. You see that there is a big diagonal up there, so we'll have to protect it. You see on that injection, we see that there is a big diagonal.
Next size, 10 is not enough. 16. No. 25, 16.
Yes, Shirish.
25, 16, Rajesh.
Yes, Shirish, we are back with you.
Hi, we are here. Just go back to where we left them. So actually, we were at a stage where we're introducing the stent, and we had said that we will introduce the reverse way, the 8 millimeter length into the diagonal. As such, it was very difficult. Okay, let me explain. You see 5 markers on that. Rajesh, can you understand what I'm talking? There are 3 markers, and the 2 back are the side branch balloon, which we can advance. So the stent is between marker 1 and marker 3. Marker 1 to marker 2 is 8 millimeters. And in this particular stent, marker 2 to marker 3 is 10 millimeters. So we actually were unable to move it forward because the stent wires got entangled. And this is the way you override it. You pull back the wires, reintroduce the wire. But it was not easy. And then we brought in previous one. This is an NC balloon to dilate the side branch in case if we had not dilated adequately. So there are 2 things. One is preparing a bed, which should be very adequate, which we are doing again here. And second is the wires getting entangled and the stent not able to advance. Next, so here we thought we will change and send the stent in a regular fashion. And this is how it is. We are teaching LAD is the main branch and diagonal is the side branch. And the stent is in position now. The mid marker should be the origin of the diagonal. And then you inflate the main branch balloon. And this is how the balloon is inflated. And now you can see the side branch balloon has been brought into position. As I mentioned to you, the side branch balloon tapers in the common segment. And right now it is beyond the diagonal origin. So we inflate with 2 inflators simultaneously. And this is what is their final position right now. So we now are going to take out the talker. Withdraw the stent and balloon system, which is the side branch.
This is side branch.
Hiramat?
You deflate it fully?
No,
Yes.
Yeah, the side, yeah, that's right. I thought that side branch balloon was too deep.
So now we have 8 millimeter stent length into LAD beyond the bridging.
What about diagonal, Shirish? Now you are going to use another stent for diagonal, for the proximal diagonal?
Yeah, I think we have to use another stent for proximal diagonal. This stent will cover just probably 1 or 2 millimeters of the side branch. So you have to use another stent.
No, that in any case for these bifurcation stents, you have to use second stent either in the side branch or in the main branch, depending on how are you using bifurcation stent. So it's not just that one stent is enough.
Take contrast, NTG.
Sunil, Dr. Modi?
Yeah.
I don't think so. See, what happens is the construction of this Nile croco or Nile pex is such that since vast majority of the side branch lesions are osteal, it covers the osteum. And this is a paclitaxel stent.
Dr. Mehta, just 1 millimeter or 2 millimeter, we are never happy covering osteum with 1 or 2 millimeter.
I think I agree with...
in a rare situation, you may be right, but normally when you stent osteum, you don't finish with 1 or 2 millimeter. I mean, it has to be
that is what this is claimed about Nile pex stent.
I think this one is, the Nile pex is designed where there's only minimal involvement in the osteum of the side branch.
The idea of making this bifurcation stent is just to give you the access to the side branch through the stent, so that you don't have to distort the stent from the main branch. I think that's the main idea. Not that 1 or 2 millimeter is enough for the side branch.
No, the main idea is that you can avoid the side branch stent.
Exactly. I think you avoid putting a stent.
What Dr. Mehta, I agree with him. Because many a times we do a main branch stenting and just a ballooning of the side branch. And when you do a ballooning of the side branch, part of the struts, they fall into the side branch. So it is not necessary that all the side branch needs to be stented. And this could even serve that purpose.
You know, they showed some of these cases in the EuroPCR this year, and they were saying that it should be used where there's only minimal lesion involving the side branch. You want to just scaffold it. And there isn't much disease in the side branch. So it is ideal for Medina 111 in some cases. But you don't have to take another stent.
That's a different situation. If you are not intending to do side branch stenting, then it's okay. But if you have a
let me explain here, because if we had gone with 8 millimeter into the diagonal, which was a side branch, I think we'd have been okay and we wouldn't have to need another stent on the diagonal. Unfortunately, when we reversed the stent and sent the stent with 8 millimeters directed towards diagonal, it did not go in. Probably crisscrossing of the wire, get a 2.5 balloon in LED.
But in that case also, Shirish, you would have required another stent in LED. So what difference
LED,
is it going to make?
That's okay. No, we are not trying to save on the stent. We are basically trying to make sure that the entire intima is very well covered. So we'll take a stent boost now to make sure you're in good position at the carina. Ready?
Another reason could be that basically you're looking for a V stenting without a crush in LED. That must be the reason that you have V stenting without a crush in LED. That might be the basic concept of bifurcation stenting.
Yeah, that is what I understand, that you get a good access to the side branch through a preformed stent.
And you cover the osteum very well.
The main stent.
You cover the osteum very well. That's a basic concept. It's not probably right just to put one stent and leave osteal then.
Having said that, we have had a few cases. We are actually trying to show you the stent boost where the side branch position looks pretty good. And we bring in another balloon in LED. We're giving an NC or no? NC. So this is an NC balloon in coming into LED. think you need a lot of luck on a given day for bifurcations.
We can put the diagonal stand lower down and then pull it because it can act as a hindrance for this balloon.
No, actually I did that. I pushed the diagonal distally. But I think the two wires are getting very close to each other. There we are, okay. Just to... So we have two metals touching each other in diagonal. I'm going to take a picture and zoom it for you. No contrast. Okay, zoom. Freeze. Okay, can you give me a stand boost? Okay, I think we're looking quite good. You have to...
Would you like to go LAO cranial and just check that where actually the ostium of the LED is, the diagonal is?
You can actually see the stand boost pretty well, Rand.
Okay.
I think I need to come back on diagonal.
Yeah.
Okay, we now look good. Again, I'm going to give you a boo.
Shirish, also check
zoom this.
Check in LAO caudal or, kind of PA caudal where you really have a maximum angle.
Why, you're not happy with what I'm showing?
No, it is, but you don't know the overlapping of the very proximal areas of
It seems
diagonal
that
or LED.
proximal marker of the stent is slightly coming proximally more. Is it that your stent is slipping away? Because distance between proximal marker and stent is much more as compared to distal marker and stent. In that I'm talking about diagonal stent.
It's difficult to judge where the proximal end of the second stent
So
and
you
the
should
diagonal
choose one
is.
stent for a diagonal with a marker exactly coincide with the onset stent itself. Because there's a lot of gap between the marker and the stent.
I'm going up.
No, enough.
Then you might miss the ostium as such. The basic concept will be lost again.
Come down. Come down.
Because it seems you have not
This is
covered
the
that
side branch.
ostium. You have still left a part of it.
This is the stent side branch.
Whatever I'm seeing, I think I'm quite happy. Okay, go up together. Go to 6.
6.
Just a diagonal a little bit more, 8,
7,
and go
8.
down.
I'm on
Go
diagonal.
down.
8, 9.
Okay, enough. Okay, so let's go on stand boost.
4, 2, negative.
I'm coming out. So we have the stand boost for you, and I'm sure you would get convinced there is no intima left uncovered. We have metal touching each other in diagonal and LED. I think I'm quite happy with the stent expansion.
Will you do IBUS after this to prove that?
We will. So you want me to IVUS LED or diagonal?
Diagonal. Just want to see how much the ostium is left uncovered.
Well, I would put it the other way, just to see that the metal is touching each other.
So what was the size of the stent in the LED? 3 millimeter?
Yes, LED is 3, diagonal
And
is
that's
2.5.
2.5. 2.5?
We'll take a picture. 2.5.
2.5.
So I think the whole idea is not to crush anything, no metal is crushed. 1 minute. Pressure, pressure, pressure. I think that result on the bifurcation. We have some issues in the mid-diagonal. I think we need to address that. But before we go off, let me show you the IVUS. And I think we'll go because that is the area where you guys are worried that is this diagonal? Are you sure?
Yeah, this is diagonal.
Okay.
Sirish, the LED proximal to the diagonal doesn't seem to be fully expanded. I think there's definitely some undersizing. So we need to dilate again.
Show you the stent boost.
On the angiogram, you look.
Just show it again, the angiogram. The angio. I think it's pretty good.
If you look at the proximal LED, is that proximal optimization?
Seriously, just after, this is Robin Chakraborty.
Even distal to the diagonal, there is a
after the diagonal, I think it is underexpanded.
No, we have to sort it out. What is underexpanded?
Just after the diagonal, the LED stent appears to be
Just
underexpanded.
make it a little forward, backward.
Just immediately to diagonal. That is some.
I think it's pretty good. So anyway, let's go on. Okay, okay, record. I can't see, you're in my way. Record on. This is the ostium of the diagonal. I think it's touching the vessel wall pretty well. And we'll soon see the LED on the side.
This is underexpanded, isn't it?
Well, I think it's reasonably well. It's 3 plus in this size. But anyway, you can still go for proximal optimization if you. We'll do all that. The whole idea was to work with you on the bifurcation, a stent which doesn't need any metal crush. It of course needs 2 stents, but we are pretty confident about not missing out the ostium. So we are going to be working on the distal portion beyond the stent in diagonal, and maybe proximal LED optimization. We would switch you back to other lab. You seen the animation or no? See it. We are showing you the animation of the stent in the meantime. Ready?
See those struts which are going into the diagonal, no? They may be enough for a ostial.
You have a long
ostial diagonal.
25
Sometimes you can manage with only one stent.
Region earlier one. Because the disease earlier.
Is it?
There was a disease earlier one. Mid part.
Yeah, we'll leave it. Are they with us? Rajesh, just check. Are they
Yeah.
Are you able to see the images of the...
Showing the animation.
Okay. Remove the wires.
Okay. So you are back with us.
Yes.
Okay. This was a situation. Show the images after opening. We changed the wire for BMW, and you see that there is some dissection proximal and sublesion up to the septal. So we decided to put a stent up to the septal. Positioning, let's say you see the angle is good, so we were quite confident that will not damage the circ or the obtuse marginal. This was our last position for positioning. You see the marker is just inside the left main. The stent just at the origin. We were happy with that. It's a 28 trio.
329.
329 from Bioman. And this was the opening of the stent. The control angiogram. You see that I think it's really, in terms of positioning, really optimal because nothing, no damage to the obtuse marginal of the circ. And you see, we are exactly at the good positioning. Distally, the stent is bigger than the artery. And if we go, if we check, you see that there is a minimal dissection distally. Really minimal. We discussed together and we were in favor of observing.
Is it a dissection?
Because
is it a dissection or a branch overlying there? There's a small branch crossing there.
No.
If you can take another view.
Yes, honestly. And we controlled 5 minutes after. And it was very stable, so we decided not to...
Take one more view.
Yeah, so what we can do now is to take off the Y and make a view without if you recenter well, okay. And because honestly, I think that there is some... mismatch between the stent and the artery, but the result is good. No good flow, and for us, no necessity of working any further. So we have a TB3 flow in this big LED, and I think a good result. And it's always good for a patient to have the LED open. He's young. The prognosis of, in terms even of remodeling of LV function, it's better prognosis now.
Madam, how did you decide the diameter of the stent, madam? How did you decide the size, diameter of the stent?
The stent diameter?
Yeah, because distally it looks very thin.
Yes, but let's say proximal LED is never smaller than trio. So no, I'm not. I don't think that we over. Let's say after opening, the artery always looks smaller, but the proximal. Would you look with the, see that the proximal LED is never smaller than? You see that this is what we saw. it looks okay, 250 like that, but no, I don't. I'm happy with the trio selection, honestly.
In these cases, will IVUS help in sizing, madam?
I would say yes and no, because this close is profoundly spasmed, and the spasm you see it with IVUS. Usually, IVUS are very helpful in terms of sizing, but when the artery is open, there it was closed. It always takes time to dilate, even if we put some nitro. So no, I just say, let's say, some simple things, like a left main is never smaller than 4O, and ostial LAD never less than 3O, even in India, where population can be with smaller arteries, but let's say they are than mine, and I'm sure I have a trio too.
Yeah, so thank you.
Yeah.
That was very well done.
Yeah, 1 minute. Yeah.
It's an excellent demonstration of
Okay.
cross-vesi to
Okay, thank you.
Very excellent cross in
Flush. Kamale.
Okay.
Just show me run number 2, huh? Just gentle. Sachin Heda Okay, we are actually working
What have
on
you
the
done till now?
distal diagonal.
After the stenting of the diagonal, what have you done?
We show run number 2 again. See, this is the pre-procedure, and the mid-diagonal looks diseased over a long length. Show the last after the stent. After the stent, before this. Okay, run this. No, show the zoom. See, I feel the stent is very well expanded both here as well as the zoom.
Shirish, I don't think you need to work.
Show me the run.
I don't think you need to work more on the diagonal, because this is a whole diagonal disease, and it is expected that the lumen will grow gradually.
Open there.
Because proximal thing has been taken care.
Show that balloon. We are actually coming in with a 230. This is a Dyer balloon. And this drug balloon has been our policy whenever we are dealing with small vessel disease. My own feeling is the ostial locations, it may not work as effectively as it would work here. So we made some initial dilatation with a 1.5 balloon.
Okay.
And this is now a Dyer balloon, 230. The Dyer balloon, as you know, the release kinetics are almost immediate, but it will stay in the vessel wall because of lipophilicity.
Shirish, do you use intracoronary Nicoran in these patients? Like this situation of diagonal?
Nitroglycerin. No, actually, that's why I showed you the lesion prior to the procedure, and there was a lesion in the mid portion always. So it was not a spasm. We are quite certain that this is a okay. So we go up.
The diameter of this balloon?
Enough. This is a 2030. And we need to hold the inflation for about 90 seconds, as you all know. Hopefully we don't have dissection.
And what is the pressure you are using?
6. What is the nominal pressure on Dior?
12.
One question.
Nominal is also 6.
Is it your practice to directly dilate with a drug-eluting balloon, or initially you dilate with a normal balloon first and then use it?
No, we did a pre-dilatation. We did that's actually it's a very good point, that we should not treat this drug balloon as a regular balloon. You have to create a bed, and the drug balloon should go with no resistance at all. In a way, it's good that we are holding, patient is tolerating it very well. We are at 80 seconds, and another 10 seconds will deflate. We'll give GTN.
With these small narrowings in between, is there a point going higher pressure?
No, I would rather not go and not dissect.
Okay.
Deflate. We've been very happy with Dior balloon, and we actually did a multicentric registry. We are in a process of finalizing the details. The initial reports are very encouraging. Rajesh, follow. The balloon result never looks as pretty as the stent results, so I'm not really disappointed. But there is a drug on there. It could take care of this relatively diseased diagonal. So I think time to quit looks like this is a wire coming out and picture.
Good, Suresh. I think this was a very nice demonstration of the bifurcation stent, and also of your drug-eluting balloon, 2-in-1.
Wait the lamp shows here.
So I think we all appreciate that, and let's give the team a hand there.
Thank you indeed, and we would continue to talk to each other from Cath Lab.
Excuse me, sir. I want to have just final comment. What we achieve after this angioplasty? We lost 4 lakh of rupee.
That time is going to tell us.
At least we lost 4 lakh of rupee, and what we do IVUS is always overestimation of the lesion. So I was guided whether we should stent. We have given more of stent load to the patient. We have given more of money load to the patient, and I think more of complication follow-up.
So I think you're absolutely right. So never do an angioplasty unless you are convinced that you are going to get some benefit.
Obviously.
In an individual case, you are the best judge. Unless you are convinced that you are going to get some result or some beneficial results, don't do it. I mean, that's absolutely taken. I think his statement is very, very valid. I'm sure the one who is doing has seen some benefit in doing it, and the time is going to tell us. Is that right, Dr. Mehta? You have some better comment?
Not right. You see, it's like this. Right from day one.
We want you to stand and tell. Yeah, well, I think this is.
I think it's an important issue. Right from day one, from Andreas Grunzig's time, where he said that in chronic stable angina, if the patient is not adequately controlled for his symptoms, then I think the angioplasty is indicated. Thereafter, there were multiple trials, Bari, Rita, Emery, and Kabi, where they compared balloon angioplasty with surgery and found that except in diabetic subsets and in those patients who had a diminished left ventricular function and there was a left main disease, there were no difference in the death except in diabetic subsets. When the stent came, the same thing. ARTS-1, ARTS-2 trial also confirmed the same thing. Therefore, apart from acute coronary syndrome, in chronic stable angina, I don't think that we are achieving anything except symptomatic relief. So in that way, if you think that way, that I think a vast majority of the patients should be of acute coronary syndrome, where I think benefits are clearly established over the medical treatment alone. Therefore, I think if the patient, if you interrogate and he said that, well, his lifestyle is such that he cannot afford to have angina, then I think you should be justified to offer him interventional procedure.
Let me also say a few things here, because we had injured this gentleman last year, January, and my decision also was medical treatment. So patient remained on medical treatment for almost a year and more. However, the injury was progressive. We still continued medical treatment till it happened that he was admitted a couple of weeks back for unstable angina. So I guess it was a limiting angina, failure of medical treatment. He was on full dose beta blocker, including Corolan. And my feeling was he was asking for it. So it's not that you see a diagonal lesion and you go for that lesion when LAD lesion is not critical. LAD lesion had to be addressed only because we're addressing the diagonal. On its own, I agree that LAD lesion probably didn't need addressing. But I was very convincing that it is a critical stenosis. Now this is the price we are all going to pay if we want to perfect the result. So IVUS, 2 drug stents is all a part and parcel of getting over the problem.
We'd like to have a comment from Dr. Khalilullah finally.
I think the IVUS showed that the LAD lesion was significant. It was an eccentric lesion, therefore the intervention the LAD had to be done. The diagonal also got opened up. I'm sure the patient will benefit remarkably with both these 2 interventions. Although the diagonal is not as big as the artery as we expected it, maybe over a period of time it might open up better. The cost of intervention is not always commensurate with the relief a patient gets. You have to realize that you do your best you can, the cath lab, and leave to the fate of the patient. But certainly in patients who have limited resources, the cost effectiveness has to be considered and carefully explained to the patient before it takes as an exercise. Nevertheless, it's a beautiful demonstration, Shirish, of a bifurcated stenosis. Give a big hand to him, all of you. Thank you. Thank you very much.
Thank you.
God bless you.
Thank you.
Thank you to all our panelists of the last session. Next session is a case presentation by invitation. Can I please call the following chairpersons on the dais? Dr. V. Surya Prakash Rao, Dr. Parvez Grant. They are the chairpersons for this next session. And the expert panelists, Suresh Vijan, Jairam Iyer, and Anil Mishra.